Hello again, everybody from SmashUrology. So we're just releasing the latest super cool feature, which is designed to help everybody with their Part 2 exam for the FRCS Urol. So if you log into SmashUrology, open up Viva's suite and check this new thing called Exam Room that we've produced. When you enter the exam room, it's got stations across all the domains that can come up in the exam. So if we choose one such as, let's take prostate cancer, it tells you about how many credits you'll use, but we'll just do a demonstration here. So the first thing is it checks your microphone works okay and make sure that you have a stable internet connection. You're in a relatively quiet place, and just to make sure you're ready to start. So we press start.
A 64-year-old man presents with PSA 18. DRE shows a firm, irregular prostate with loss of the lateral sulcus. MRI demonstrates extracapsular extension, CT3A, without seminal vesicle invasion. No distant metastases on staging imaging. Transperineal biopsy shows Gleason 4+4, grade group 4, prostate adenocarcinoma in multiple cores. Past medical history includes ulcerative colitis controlled on mesalazine. Performance status 0. Are you ready?
Yes, ready.
How do you risk stratify this patient?
So this patient will be risk stratified according to both EAU and the CPG criteria as a high risk, given he has T3A disease and he's grade group 4. He meets the high risk on both of these despite his PSA being less than 20. This means he's got a higher risk of extracapsular disease. I also note that you mentioned he's got ulcerative colitis, which creates a challenge for radiotherapy considerations in future.
What staging is required and what is the preferred imaging strategy?
So staging usually require in the high-risk group PSMA PET as per the latest EAU 2026 guidelines. If that's not available, then cross-sectional imaging with CT scan and bone scan would be appropriate.
Please elaborate on the evidence supporting PSMA PET CT for staging in high-risk patients.
There's been a couple of trials. I think the EAU refers to the pro-PSMA style, which demonstrated the efficacy and accuracy of PSMA being enhanced over CT and bone scan.
What information from MRI is most important for planning surgery and radiotherapy?
So I want to know about the extent of extracapsular in extension, if it's feasible for surgery or radiotherapy, the relationship to the neurovascular bundles, for consideration of nerve sparing, if that's appropriate. I want to know about the burden of tumor, the volume, the size of the prostate, membranous urethral length, and anything else that might increase margin risk.
What curative intent treatment options are appropriate, and how does ulcerative colitis affect the discussion?
So it would normally be discussed between radical prostatectomy in high-risk disease or radical radiotherapy. Ulcerative colitis obviously affects this because it reduces the feasibility and increases the toxicity risk from pelvic radiotherapy.
If surgery is chosen, what operation is offered, and what is the role of pelvic lymph node dissection?
It's a highly debatable topic. With robot-assisted radical prostatectomy, some centers perform pelvic lymph node dissection and others do not. In high-risk disease, I think the evidence suggests that we no longer need to do that, but there are some current ongoing trials to explore this. Yeah.
Are you certain that pelvic lymph node dissection is no longer needed in high-risk disease?
It's an area that's being investigated at present.
How is nerve sparing approached in CT3A disease?
I'm not sure.
What are the key operative steps of robot-assisted radical prostatectomy, and where are the main technical risks in this case?
So we'll just stop here and by pressing stop. And what you find is it tells you how many credits you've used. If we press generate AI feedback, this is actually really cool that we've built, and it will analyze the Viva session with real life scoring. So you can see that on my basic knowledge, I've scored 5 out of 8, higher order processing, 5 out of 8. But I've passed on clinical skills and my professionalism. Um, this marks it in the exact same way as it does in the actual Viva. It gives us recommendations on what we've done well and areas for improvement with an overall impression. So try it out. Reach out to me if you want to do some testing, some free trials as well. Happy enough to do that. And your feedback is always, always massively appreciated. We look forward to hearing from you. The feedback so far has been super. So let's keep that up. I'm all about learning from what everybody feeds back to us. And yeah, let me know what you think. Thank you so much.